Hi, everyone. My name is Paola Bello. I am the Director of Innovation at Harvard Medical School Center for Primary Care. We are excited to be partnering with MIT Global Bootcamps on our second annual Healthcare Innovation Bootcamp that will be taking place this June, the 15th to the 21st. And we are going to be accepting applications for early bird up until March 1st. So if you want to get in that early bird special, I urge you to check out the information on the MIT Global Bootcamp website and apply today. So on today's e-seminar, we are going to be hosting Rick Sahu, who is the co-founder of OneUp Health. Ricky was also one of our fabulous speakers in our August bootcamp, and he's going to be talking about how to start a company with electronic health data. I also love Ricky's story because it's one about understanding gaps and opportunities in the market. So sort of pay attention to that through his presentation. I will let Ricky go through his presentation, then we're going to leave some time at the end for Q&A. But as you're listening to the presentation, if there are questions that come up, go into your Q&A box and put them in there, and we'll be moderating that. So I'll give you a quick intro on Ricky, and then we'll pass it over. So Ricky is a data and systems whiz. His experience spans machine learning, building scalable technology, circuit design for IoT, and blockchain smart contracts. He started his career at Google and also worked at Promediacorp, working with clients like Sony, Microsoft, and Forever 21. He shifted into healthcare when he joined health tech startup CareJourney, and in 2017, he co-founded OneUp Health, where his company aims to bridge the gap between patient-centered data and provider needs by using patient-generated data to enable applications to improve healthcare outcomes and reduce costs. So with that, I'm going to pass it over to Ricky to start his presentation. Thanks, Ricky.
Thanks a lot, Paula. Hey guys, I'm Ricky Sahu. So as Paula said, I lead a company called OneUp Health. And what I wanted to share is more information about how to work with health data today and how to build a company around it. There are a lot of interesting challenges in the US healthcare industry with interoperability, access to data, security, privacy, and also policy. And as those different facets shift, they create opportunity to build companies and large companies around those shifts. So there's a ton of data in healthcare. There's patient data and there's health system data. And there is a bunch of other metadata around it. But what's most accessible today are these two types. And on the patient side, you have clinical data, which is like demographics about individuals, medications, procedures, images, lab results, etc. And that data is also within the health system, but it's required to be patient-facing. So the patient should have access to all this information. On the health system side, there are orders for requests that docs have made for something to be done at the hospital. There are doctor-to-doctor notes, which are not always made visible to the patient because they may be very esoteric or confusing, or they may be alarming to individuals and they don't need to be presented at some time. And there may be like a time frame before they're public to the individual. There's also bed assignments, so like where is the patient at the hospital? And there are things like claims data, which allows health systems to say that a certain procedure or medication costs a certain amount so that they can be reimbursed from the payer organizations. So those are more on the operational side. And depending on what kind of information you need access to, you may need the access to the patient-facing data, the health system data, or both. So the primary source of this information is largely the EHR. And there are a few big electronic health records in the US. The biggest one is Epic, and depending on where what your background is, you may or may not have familiarity with these organizations. But Epic is usually the most predominant. Then there's Cerner, Meditech, and many other smaller organizations. Generally, the larger EHRs here are also embedded at the larger health systems that have, many millions of patients, and the smaller EHRs are naturally for smaller organizations. But the point here is that if you can support some of these larger EHRs, then you can support a larger chunk of the healthcare industry and the data that flows through it. And the data that comes in through healthcare is usually governed by this body called HL7, which stands for Health Layer 7. And that is really the interface between applications and the health system data. And there's been a big transition in the way that this health data is created and also transmitted. So predominantly, those EHRs that I presented on the first, a couple slides back, they are required to support this HL7 V2 format, which is this first, top gray box. And as you can see, that is very difficult to read as a human, and it is not meant for humans to be reading. And in order to also process it, it requires a lot of domain-specific knowledge that is not really accessible to many companies or app developers today. So there's been this transition from the HL7 V2 model, which is that pipe delimited format, to where we are today, which is called FHIR, F-H-I-R, which stands for Fast Healthcare Interoperable Resources. And but before we got to FHIR, we were in this middle ground, which is called a CDA, as consolidated data document of all of the information for a patient's history. And that format had a lot of flexibility, which made it difficult to create consistency around, especially when getting data from multiple organizations. So there is now this new API called FHIR, which is mandated by the federal government, and that is allowing atomic access to data. So that atomic access means that you can request very specific information, like show me this patient's diagnosis on this date, or show me this patient's blood pressure reading, or show me all the patient's blood pressure readings that were higher than a certain value. Those are things that you can do with FHIR, versus HL7V2, which would send you all the data and require you as the developer or the receiving organization to parse it and put it into a format and data store that you could then query. FHIR kind of has that all built into it as both means to structure the data, transmit it, and access it for various use cases. The CDA was kind of in the middle, where it was a little bit more structured and readable, but it still didn't allow you to interact with the information. So now, and there have been various phases of the government that have taken us from this HL7V2 to CDA to FHIR, and that's basically a transition that has been propagated by policies that the US government has mandated. You don't have to integrate with those EHRs yourself. There are many organizations that do this. So there's self-service tools like Mirth, which we also use internally. There are paid ones like MuleSoft, which does kind of like what Mirth does in healthcare. And then there are services companies like Redox, Datacup, PocketDoc, and Human API and OneUp that package it all together. And we all have different kind of takes on it, but the point is you don't have to do it yourself, though you can. And if you do, I would recommend, the open source tool Mirth. There, like I was saying earlier, there are a bunch of rules that have been created in the US government to require access to data, but also secure and protect that access. So HIPAA is probably the most prominent one and most familiar to you guys. So basically what it requires is for any organization that is working with healthcare data and has a model where they're getting that data from another system without being given explicit consent from the patient, they have to then work with that health system and protect that data so that it is secure in both transit and at rest, which usually means you have to encrypt the data access. And that is, this HIPAA requirement is to cover data that is transmitted between organization to organization for masses of patient information. The patient-mediated data is not covered by HIPAA, and that is the case where a patient is saying, hey, app, I want to use you, and in order to make my experience better on your application, I will share my personal health information with you, but you won't have access to anyone else's health information. I'm explicitly saying you get access to my data. In that case, HIPAA does not apply, but because this is health data and people are sensitive about health data, we believe that it should be stored in a HIPAA secure manner. So all the data went up, we secure in that manner, but legally it's not required to be. Then another kind of analogous part of HIPAA is this business associate agreement. And a business associate is called a HIPAA covered entity, and they're like hospitals or insurers, and whenever, or even vendors, which may be a business associate, those vendors, when they work with this HIPAA covered entity like a hospital, they have to have a business associated agreement between them in order to share data that contains PHI. So for example, if OneUp Health works with large organizations to get that HL7 V2 data in, then we have to have a BAA with those organizations. And that's kind of just giving you a little bit of background about the rules that are required. But what we've seen is this progression of additional standards and rules being created by organizations to make it easier to gain access to this data for patients, but also create incentives for these provider organizations to make sure that they provide that access to patients. So there have been these historical rules called meaningful use, and they've been launched in phases. So there's meaningful use 1 in 2009, meaningful use 2 in 2014, and they basically used a carrot and stick combo of incentives to get health systems to make their data available to patients, and also make sure that doctors have the right technical tools to interact with health data. So in 2014, this new rule called Meaningful Use 2 required that 5% of patients must be able to view, transmit, or download their electronic health data. And about 80% of provider organizations across the US went forward with that. But that 80% really was a larger chunk of patients, because a lot of these larger organizations had to support it for their patients. So probably 90-95% of patients have the ability to do this with their data, if not more, at this time. But there have been some new rules that have been introduced in Meaningful Use 3. And this is really where OneUp Health's business model comes in, and many other companies as well. So now under Meaningful Use 3, patients can authorize access to clinical data to any app of their choice. And this is something that anyone developing a consumer app or anyone requesting access to consumer data for a health system or a payer or pharma company or whatever, they can take advantage of these new rules in Meaningful Use 3 to access data in this standardized FHIR methodology and push it into their application. And before this rule, oh, by the way, the interest in FHIR is growing very rapidly since this happened, and it's basically doubling every 2 years. And it's already half the interest that there is with the second most popular EHR, which is Cerner. So within the next couple years, you can think of FHIR as having the same level of interest as like one of the top EHRs in the US. And before this, in order to gain access to your patient's data, you would essentially have to have a business associate agreement with each health system. And that business associate agreement takes many, many months, if not years, to secure with an organization. So getting access to data was essentially untenable. And you were having startups and other organizations with awesome ideas creating products, but never getting access to the data, and it was essentially killing innovation before it even started. So now with these new rules, you're able to gain access to this information and really launch nationally without having to work with every organization directly. And that's really creating a ton of new opportunity. So we saw this happening at before we started One Up Health, and we saw that new Meaningful Use 3 rules were being created, and there were new APIs that are making this data accessible. So you're getting a ton of additional information that you previously didn't have access to before. And these new rules were essentially creating like tectonic shifts in the industry and opening up huge gaps and creating new land for companies to build upon. And what we thought about doing, at first, like when we were thinking about what to do at One Up, or when we were thinking about how to create a new company to fill this space, there are many options there. And but one kind of common thing we kept seeing is that there are always companies that were going to need this connectivity to EHRs via the Meaningful Use 3 regulations. And when we started accessing data for these health systems, we saw that their data was not always complete, and it was not always conformant to the standard, and their implementations to get access to the patients were also varied. So we realized, a bunch of organizations are going to have to go through the same problem of integrating with these organizations, even though they had, technically they have access to it. Making use of that information is still difficult. And if we created a foundational platform layer that was underneath those orgs, then you would be able to facilitate this data access for many other companies. So there are all these environmental shifts happening that made it possible for One Up Health to do what it's doing. So like I was saying earlier, that Meaningful Use 3 mandate was huge from the government. That was a big change in policy. Patients now with smartphones had tons of clinical data essentially in their pockets. There are also these big shifts in policy transitioning the US to more of a value-based care incentive structure than a fee-for-service one. And what that means is that, what value-based care means is that healthcare healthcare systems must be responsible not only for doing the quality of care, but also the cost of it. And the way that it works is that health systems are now sometimes given given their check from CMS or from other organizations for a bundle of care. So, for example, if they are performing a knee surgery, the healthcare system will be paid $25,000 total for all the care that leads 30 days up to the knee surgery and like up to 90 days after it. And if the patient is readmitted or if they have other complications, then the health system is basically footing the bill for that. They're not going to get paid more. They're only going to get that 25K that they initially got from the government. And that's creating this incentive for the health system to really understand their patient, both within their walls and outside their walls. And it's that outside their walls, like that external data, that is creating demand for this meaningful use-free data that is now being made available through the government mandate. So really, both on the supply side of the data and the demand side, there are synergies happening that made our potential market grow. And then we've already talked in depth about FHIR, but there's a ton of interest around it. And these app developers that are now taking advantage of it need somewhere to work with this information. So, we're solving this big problem of getting access to data where usually it takes years because you require a BAA relationship. But instead, you can literally get EHR data in minutes today. And the way that we decided to package this all together is through a healthcare API platform that allows developers to connect to FHIR data, but also manage clinical data from sensors and user permissions and pull it all together with a bunch of open data from the government. And this open data stuff is also, you can think about it as creating opportunities for businesses or startups. Like just recently, in January 1 of this year, there's a new initiative that, the initiative was launched previously, but in January 1, hospitals have to now publish publicly their full cost of all of the things that they do at that organization. So you can now go to like UNC's website and download the charge list for everything that they do. So these kinds of, information creation or the new information that is made available to the public can then be used by companies to create an unfair advantage of an asymmetry of information that they have that can then be used to create a business around. And what we're doing is we're basically bringing together some of this open data that has been made accessible from the US government and other sources, and enabling app developers to use that. And some of that includes like the national provider identifiers of all of the doctors and facilities in the US, the ICD codes, which are medical coding terminologies for diagnoses, and a bunch of other medical coding terminologies, which are often used in healthcare. So this slide's a little out of date, but the last time we presented, which was maybe 6 months ago, we were supporting about 150 health systems. And today we're supporting 280 health systems. So that kind of also shows you, what kind of, how many organizations can be made to move by simple policy changes from the US government. And really the opportunity that you can capitalize on if you look at those big shifts from the industry. So what this means is that about 2/3 of the entire US population can be supported with patient-mediated access via the connections that we have to these health systems. And therefore, any of the apps building on OneUp can also have that national reach across the US. And this isn't only a US thing, actually. Like, there are a lot of organizations in the rest of the world that are building towards this model, also supporting FHIR. So specifically, I know that the EU is working on this, Australia's government is working on this, Canada is working on this, Israel is working on this. So it's all over the world, literally, and it's only growing with time. So, you know, you can ostensibly, in your application, be able to support a worldwide set of patients, where before you were only being able to support single institutions at a time, where each institution took a whole year to onboard. So it's really shifting the industry tremendously. OneUp also has a couple user-facing products to make it easier to access data and share it between patients and providers. So we have a patient-facing app, which anyone can go online and use today. And that patient-facing app can be used to view all of your medical history from various sources, but it can also be used to share data with provider organizations. And I think that's really where things like this become powerful. Like, our app is just one implementation of this. We have many other developers building on us, about almost 200 now, that are using us in similar methods. And they can develop very specific or general use cases around certain conditions like cancer, certain verticals like insurance, that were not possible before because you just didn't have access to the data. So this is an example of an app that was built on OneUp. It's an AI chatbot that is in Facebook Messenger, and it only took 2 weeks for the organization to develop. And not only could they demo to their client, but they can also demo to 280 other health systems across the US. I have a couple other slides that I actually want to share for some of the other apps that have been built on us. Just let me. So there are a couple of questions that I'll cover right now. So, how complicated is it to receive FDA approval as a digital therapeutic? So that it really depends. Like, we have organizations that are using OneUp Health to connect to EHR data for their digital therapeutics. So we know a little bit about this, but it can take, the FDA approval process can take like a year or more, depending on kind of where you're at. But it is not a simple thing, but we do think that it's valuable, because at that point, your product can essentially be used by or prescribed by any provider organization. And what OneUp Health, or not just OneUp Health, but what these meaningful use 3 rules allow you to do is be able to launch at any of these provider organizations, have your patients at any of those provider organizations be able to use your digital therapeutic with all their data. Another question was, when we're talking about health systems, what does like a health insurance company fit in there? So the health systems that we had on that slide are specifically healthcare providers or organizations. So mostly providers, but we do have Medicare, which is essentially health insurance. And there is going, from what we understand, talk about regulation, which will require health insurance providers to also make their claims data available to patients across the US. So in that case, we'll also be able to support those health insurance companies, and app developers will be able to build products relevant to them as well. So one of the other questions, how does OneUp Health manage high demand for EHR data transfer between systems? how do we scale? So the way that we're building our technology is, so there's two questions around this, I guess. One is on the technology side, and another is more on the business relationships, access, and permission side. So on the technology side, the way that we've architected OneUp Health is to be as much as possible a serverless product. And what serverless means is basically use cloud native solutions from like, Amazon or Microsoft or other cloud, like Google cloud vendors, that allow you to use their platform without having to manage servers on those cloud services. So what that usually means is taking advantage of like API gateways or cloud functions like Lambda or serverless data stores without having to install software on specific servers. And what that gets you is this ability to scale by just clicking buttons. So we used to have to manage servers because of HIPAA requirements and the fact that we're on AWS, the fact that they didn't support, AWS didn't support HIPAA for certain technology that we wanted to use on serverless. But recently they did roll out support for that. And we've been transitioning everything that we've done to a serverless model. And before we were on a serverless model, we would have to essentially provision nodes for databases, and when we got new data in, or provision more servers to be able to address spikes in data transfer between systems or patients. And things would go down and it would set off alarms in the middle of the night, and it just wasn't fun. So since we've gone serverless, we've had like literally zero downtime, and I don't have to worry about that anymore. And to scale, like, you can essentially turn on auto scaling, and you don't have to worry about managing servers or provisioning new nodes and things like that. So there's a saying with people who use serverless that friends don't let friends manage servers. And I would definitely give you guys all that advice. It just makes things a lot easier to build, especially as a small company. The next question is, can these advances be expanded to other countries such as Latin America, and how much time could it take? So yeah, definitely. Like these can definitely be expanded to other countries. We've had Latin American countries contact us to get access to data. And these EHR providers are also, international. So there's no reason that they, a Cerner install or Epic install in another country can't provide the same level of access. But there are different rules in a lot of local organizations and EHR companies that don't yet require this level of support for FHIR. So what we are seeing is that other countries are doing it, and they're starting to like make this data accessible in that manner. But there's still a considerable amount of time, because in the US, what happened is there was a kind of a coalition of the willing that formed ahead of the rules and regulations that decided and this was a coalition of a bunch of the EHR organizations and other players in the industry. And they decided together to test out FHIR servers, build out the technology, and make proposals to the government that before they mandated that this would happen. And that created a lot of lead time for product development here in the US. And when we're working with other countries, we also advise them to follow that lead and socialize this with local vendors and players that have healthcare data before delivering the mandates. And the great thing is that a lot of countries, in addition to the US, have already have already laid a bunch of foundation with FHIR. There's a huge international community around FHIR. Even the founder of FHIR, he is based in Australia. His name is Graham Grieve. So there's this huge international community already about it. So there's no reason it can't be used elsewhere. It's just a matter of bringing some sort of incentive onto those organizations so that they can enable access at a national level. How are we ensuring that we have permissions for data coming from the EHR? Or is that ownership sitting with the health authority? So the way that it works is that for the patient-mediated access is that we will show the patient a list of health systems that we support connectivity to, and the patient will click connect on that health system. And when they click connect, they will be sent to that patient portal for that organization. And on that patient portal, they'll sign in and say, I want to authorize access to OneUp Health to use my data. And when that happens, the health system is giving us a token to access that individual patient's data. And then we can query that data and improve services for that individual. So it's really sitting with that as like a contract between the health system and the patient to make that patient's data available to OneUp Health or any other app that wants to use it. For access to bulk data or to many patients at an organization where we have a BAA, we have that direct relationship with the health system, and we both agreed to not share that data with any other party. And we don't share the patient-mediated data with other parties either. But in that case, that is a requirement by law. And then again, the ownership is ultimately with the health system of that data. But as a business associate, we get access to that data to make to improve services for that health system so that they can provide the patient with whatever they need to provide them. So another question about tech and scale. So what tech stack and architecture are we using? So basically our tech is built in Node.js on the actual coding language side. We have both relational data stores and non-relational, as in like NoSQL data stores as well. We have actually 4 different data stores used for different access patterns. One for accessing, just an individual piece of information, another for being able to query across different resource types, and another for analytics, and another for historical data storage. And then because we're getting, a stream of messages from these health systems and also spikes in load whenever a new connection is made, we do have a queuing mechanism. So like I was saying earlier, we are on the AWS stack, so we're using SQS for a lot of this stuff. And there are a bunch of other tools on other stacks that you could use, or you could run servers yourself. But again, we have kind of that architecture in mind where we don't want to manage these servers, so we're using whatever our cloud services provider has. Next question is, if I don't use sensitive data like name, social security number, do I need to worry about the legislation rule? So it depends where how you're getting access to that information, and also what other information you have, because there can be a lot of things that can be used to get back to identifiable information. Like if you have a patient with a very specific condition that only a handful of people have in the world, and you have things like zip code, then you may ostensibly be able to get back in some way who that patient may be. So it's a little bit more nuanced than just removing the name, social security number, and birth date and stuff like that. For the HIPAA protected BAA data. For the patient-mediated data, like I was saying earlier, that is not legally bound by the rules of HIPAA, but we strongly advise that you protect it in the same HIPAA-compliant manner and you treat it as if it were, because you don't want your data to leak out and be used for malicious purposes. And if that were to happen, that would be a big reputational scar on your organization or your company. So we take it very seriously, and we basically don't share any data with anyone that the patient has not explicitly authorized or the health system has not explicitly authorized for treatment purposes, and that is in line with the HIPAA rules. So what is the role of healthcare providers in the development of this technology? So I think there's definitely an existing role where healthcare providers at these health systems are working with their EHR organizations to gain access to the technology that enables this sort of information transfer. But after that information has been transferred, I think really most of the onus is on those healthcare providers to create the technology that is useful for them and for patients, because they're the ones that are interacting with this data most of the time. I mean, patients may be interacting with it, but like the average person looks at their healthcare data, maybe 10 minutes before and 10 minutes after they go to for some sort of healthcare visit. Chronic care patients obviously look at it a lot more, but healthcare providers are looking at it all day long. So I really think that there should be more of a role that healthcare providers play. And I think part of it is just that this data hasn't been accessible in the way that it's now accessible today. So I think now there's more opportunity than ever for, like groups of, people that are in tech and people that are in health to work together, get their hands on this data and make it accessible in a useful way for patients and other providers across the world. So the next question is, I would like to ask if it's possible to provide an example of relevant data analysis that was possible to perform using medical history of patients. Yeah, so one of the things that I wanted to show you guys is, so this app here, let me see if you guys can see this now. So there's this app called CureSoft, which built on OneUp Health. And what they do is they created a product that allows cancer patients, really any patient, to see their full medical timeline across various health systems. And in this case, the patient is connecting 4 different health systems in one view. And what you can see is that there's this treatments line up here, and there is another view in this app that shows treatments alongside medical observations. And what CureSoft has been able to do is they've been able to see these treatments alongside those observations and lab results, and see that certain treatments are having positive effects on these lab results versus other treatments which are having no effect. And they can then take this and work with the providers and the patients to say, hey doc, like this is one's doing, this one's actually improving my care, this other one isn't. And then the doc can advise doing more of what is actually beneficial to the patient. And this is like something in live in production. Patients are connecting their data, patients are showing this to their doctors, and hopefully it'll be out for general availability soon for a wider population as well. So that's just one example, and there are many other use cases like this as well. Let me go back to the other questions. Okay. So I have a programming background. How can someone with little or no background in programming tap into this opportunity? So I think one big thing is that this data is being made available in a way that is much more accessible than ever before. So the level of effort now to gain access, even as a non-technical person, and launch an application with connectivity to this data is more accessible than it's ever been. But that still might require some technical experience. So one of the things that you can kind of think about is what are the opportunities that are now being enabled by the availability of this data. And one of the big things is that you can now finally see data from disparate sources in one place, like this CureSoft app. And you can think about ways that those separate data in a single place can be leveraged, for example, for research or better care coordination, or care for the patient, remotely, or for things like onboarding new patients at your system, or even things like, competitive intelligence, for example, like you can know what other health systems are doing that you may not be doing. So I think there's a ton of opportunity that is being created with this data. And you can kind of think about it as like, the internet before you had a bunch of big companies building products for the internet. So there were people creating websites, and there were people communicating in forums, and there's email, and there are a bunch of other things. But like then people realized that there's now all this data and it needs to be organized, and you got a bunch of search engine companies. So there's like a bunch of stuff that can be layered on top of just having access to this data, from like the policy side and from like the care coordination side, that I think you could think of in a way that's very different from before having access to this data. Is there a similar pattern to FHIR for sharing data generated by health accessories like Garmin, Apple Watch, blood sugar, pressure monitors, and glucose meters? So yeah, so with FHIR, there is the specific resource type called an observation. And what we've been doing is we've been integrating with things like Fitbit and Google Fit and others to bring in that observational data like a heart rate and push that into a FHIR resource. So what that then allows you to do is you can query for a patient's blood pressure read or heart rate reading, and see data side by side from the health system and the device that they're wearing, which is pretty cool, and it could be used for obviously remote patient monitoring and a bunch of other stuff. There are also other standards that enable this, like Open mHealth is another one that works with observational data. But we've kind of at OneUp decided that FHIR is the way that we want to go today, and we're transforming everything into that method. Okay. After the patient gives consent to share their data, is there any way for the patient to know whether data has been sent, used, or shared with? So right now, the patient has to essentially trust the organization that they're sharing data with. So that before the patient consents, there's like a whole screen that says, do you accept the terms of sharing? There's a privacy policy for the application. And then there is also every single bucket of information that will be shared, like, where you share your allergies, immunizations, labs, procedures, etc. But technically, there is no way for the patient to be assured, and this works, even when health systems are integrating with a third-party vendor, for that health system to be assured that their data is not being, sent somewhere else or used in a way that it wasn't supposed to be or shared with someone else. And we definitely at OneUp, we understand, like personally, like I definitely understand that is a limitation with the way that the world exists today. And our approach to that is to slowly shift the world from the way that it exists right now, which is take your data and send it to the app, to a world which is bring the app to your data. And that's really where you can then be confident that your data is not being used for a purpose that you don't want it to be used for. Like every kind of piece of information stays within your org, and you are the one that is controlling what goes out. And I think this is a big problem at health systems today that kind of is underappreciated or not given enough attention to, because you see health systems get breached, or services get taken down because some hacker wants some Bitcoin or whatever, but or like if data gets held hostage or that kind of stuff. It happens today, but there is this whole world of healthcare vendors and organizations that are undergoing audits, including us, but you don't really know what's happening to your data after it goes to those organizations, whether it's an individual patient's data or whether it's your whole institution's data. And we really want to transform that again to a bring the app to the data kind of model, where technically you can protect against data leaking and you really know where all the information is going. There are also some like blockchain thoughts around this, but that would essentially require the entire application to be running on the chain, which would, in today's world, not be a very performant experience. But I think like there are models that could exist in the future. But you also have to kind of think about, the fact that storing data in the blockchain, especially healthcare data, may not be as secure, after like quantum computers come along and stuff like that. So can I explain how we use machine learning in our applications? Yeah, so we don't do a lot of it, but there's a ton of opportunity for this. So one of the things that we have is a long short-term recurrent neural net that uses the patient's medical timeline and has been trained on all other patients' medical timelines to then be able to predict what we think is likely to happen to this individual in the next X months. And we have, because we've trained it on like hundreds of thousands of patients, we're able to find really nuanced, be very specific in what we think will happen to the individual. Like we think with X% likelihood that this patient will, encounter this new ICD code in the next months, or undergo this procedure with a specific CPT code, or things like that. So that's what we've done so far. That's more of it hasn't rolled out into production yet. We're talking to some organizations about using that, but it's not there yet. But we're also going to make that available via API to all the app developers so that they can just feed in their patient's history and get out a risk assessment and use that in their own applications. What type of encryption are we using to guarantee security issues? So, so basically, all the data that we store and transmit is encrypted, and we're using industry standards for encryption, like 256-bit encryption, and that is for all the data that we work with, and even backups, and we make sure that all of the web services that we run, run over HTTPS. We don't store any data off of AWS, and even any peripheral work that we do with blockchain doesn't have any data on there. So everything is encrypted. But like really what we've seen, so we participated in a healthcare challenge from the ONC or maybe from the HHS to be able to hack a open source Fire server. And we were able to find access to any patient's data for any period of time for any app that the patient has shared data with. And what we really understand is that the hacks are not going to happen because you didn't use the highest level of encryption. They're going to happen because engineers or developers building product may have interaction effects with other parts of your product that someone else worked on that create security holes. And it's those types of holes that basically give access to data beyond like the encryption side. So it's really important to have awesome testing infrastructure, but also be very, I would say, more careful on like the application logic side than anything else when building these products. Currently, there are mental health applications that have provided. Currently, are there mental health applications that have provided data relevant to the patient? So we have some mental health apps and working with patients using their clinical data that can be shared from the EHR. And I'm not 100% sure like what exactly their business model is or how they're working with those patients, but like there are some around improving headaches and some around improving depression and things like that. And the cool thing is that now like you have all this research around mental health, specifically with depression and social media posts. And One Up Health and these EHRs are making data available via their actual information in the clinical data repositories. And what you can see now is a possibility of this social data, like the filters that you use on Instagram, coming together with this clinical data and being used as like a training set, but also being able to facilitate information transfer between the patient and the doc, obviously with permission, on how maybe you can find some information that leads to the doc wanting to reach out to the patient more directly to prevent a more serious like issue or condition in the future. So I think there are already some apps working on stuff like that, but I think the game is still very early in that realm. I think there's a ton of opportunity there. Cool. So I think we're at time. Paul, I'll let you.
Yeah, thanks so much, Ricky, for a great presentation and some thoughtful responses to some really great questions from the audience. And thanks again to all of you who joined us today. As a reminder, if you're interested in learning about the Healthcare Entrepreneurship Bootcamp starting on June 15th, check out the MIT Bootcamp website. Early bird deadline is quickly approaching on March 1st, so I encourage you to reach out and ask us any questions. So again, thanks everyone. Hope you enjoy the rest of your day wherever you are tuning in. Thanks and bye-bye.
Yep. Bye.